Welcome to Somerset Medical Center's Health Talk. I'm Dr. John Bucek, Director of Somerset Medical Center's Family Medicine Residency Program. Colorectal cancer is the second leading cause of cancer-related death in men and women, but is also one of the most treatable cancers. Due to early detection and prevention, the death rate from colorectal cancer has been declining over the past decade. On today's show, we will talk about what you need to know to reduce your risk for colorectal cancer and the important tests you need to detect the disease in its earliest, most treatable stages. Joining us to discuss colorectal cancer are our two special guests, Dr. Tony Frisoli, a family physician on staff at Somerset Medical Center, and Dr. Alan Gingold, a gastroenterologist at Somerset Medical Center, who is a member of the Colon and Rectal Cancer Institute at Steeplechase Cancer Center. Welcome to the show, gentlemen.
Good morning.
Why don't we begin by giving our viewers an overview of, what is the colon, what is the rectum, how do they help us in normal function and digestion?
Well, the colon is the lower end of the digestive system. There's roughly about 4 feet of colon. It starts on your right side, your right lower quadrant. That's called the ascending colon. Then it kind of makes a left-hand turn, goes across your abdomen. That's the ascending colon. Then it goes down, becomes a descending colon into your rectum, and then you evacuate feces. Basically, the right side of the colon digests your food and absorbs most of the nutrients. As the food material travels through the colon, water is absorbed and it becomes compacted. And then the left side of the colon basically stores the feces and evacuates the feces to eliminate your waste.
And, if that's the normal functioning, what is colorectal cancer?
Colorectal cancer is really just, it's the abnormal cell growth, which is really what a cancer is, that occurs in the colon. When this occurs, it can affect absorption. It can affect, which is why some people will get a change in their bowel habits. When they do have a colon cancer, it may, some people get diarrhea, some people actually get constipation because it can actually grow large enough and cause a blockage.
Can colorectal cancer happen in any part of the whole colon? As he was describing
yes, it can.
Long.
It can happen really anywhere, all the way from the anus through the cecum, which is the last portion of the colon. And that's why it's very important when you get a colonoscopy to have the whole area looked at. They used to do flexible sigmoidoscopies, which was really an examination of the left side of the colon. But about 30 to 40% of all colon cancer occurs proximal to the left side of the colon in the transverse and ascending and cecal region.
So we have a little overview of what this part of the intestine does. Now we know what colorectal cancer is. Why don't you tell us a little bit, what are risk factors for colon cancer? What is it that makes people more likely to have it?
There's a lot of risk factors, actually, and there is a little controversy in regards to risk factors, but the first risk factor would be age. Mm-hmm. Anyone over the age of 50 is at higher risk. Family history is very important. If you have a family history of colon cancer, first-degree relative, you have a 2 to 3 times greater chance of developing colon cancer. Some other risk factors include inflammatory bowel disease. People with ulcerative colitis, Crohn's disease are at higher risk. People that have had previous cancers, breast cancer, ovarian cancer, uterine cancer are at higher risk. African Americans are at higher risk. Diabetics are at higher risk. People who smoke are at higher risk. People who drink are at higher risk. Basically, there's a lot of people at higher risk. And then there's some dietary factors that come into account. Some people feel that if you have a low-fiber, high-fat diet, you are at higher risk also of developing colon cancer.
Some of the things you mentioned sound like you're not able to change them. Your family of origin, for example. What are some of the factors that you counsel patients, things that they can change, things that they can do to lower their cancer risk?
Well, some of the things you can do, for instance, you can change your diet, certainly. If you have a high fiber, low fat diet is very good and prevents or decreases the risk of colon cancer. Experts say that eating lots of fruits and vegetables can decrease the risk. Obesity is another risk factor, so weight loss would help, stopping smoking would help, exercise would help. So we could be talking about heart disease now, and all those things help heart disease. Those are just good, general, healthy things that, I recommend that patients do as a routine.
That's a good point. So you could be focused on colorectal cancer and reducing your risk, but you're actually going to help yourself prevent other preventable conditions as well.
Absolutely, absolutely.
Certain groups, because of age or because of risk factors, are at higher risk. Can you go over what are patients supposed to do? What is the recommendation for screening? And who tells us what our recommendations are for screening to try to find colon cancer?
Sure. As far as screening goes, a lot of it is based on, as you said, age, but as well as your risk factors. And depending on the risk factors, will help determine when you should be screened. So if you're average risk, meaning that you don't have any predisposition to this, you don't have inflammatory bowel disease, you don't have a family history of colon cancer, the average person should start screening at the age of 50. Dr. Frisoli had mentioned African Americans, and that's true. There is a recommendation now that they should begin screening at the age of 45 because they are at higher risk. It is a little controversial, but the American College of Gastroenterology has also made a recommendation that you should at least consider screening at the age of 45 for people who are severely obese, who have a significant smoking history, as these do increase the risk of colon cancer. But as of yet, those are not official recommendations, so likely insurance companies may not pay for that at this point. Now, if you have a genetic predisposition or a family history, your screening would occur earlier. Typically, it's about the age of 40 or 10 years before the youngest person in your family had the cancer. But there are other conditions like FAP, which is familial adenomatous polyposis, which is a congenital condition where you're born with just hundreds of polyps in the colon. Those people, inevitably, everyone gets colon cancer at some point, about 95% or greater. And in those people, usually we start doing colonoscopy as soon as the age of 20 or so, and they eventually will get a colectomy. They'll actually have to have their colon removed because of the high risk for cancer.
Oh, there's different ages for a lot of different groups. Mm-hmm. So you have to sit down and talk it over with your doctor and figure out which group you're in. It's not as easy to remember some of the other screening guidelines because it really has to do more with figuring out your risk.
Absolutely, and everyone should be encouraged to see their primary doctor, discuss with them what their risk factors may be, and know your risk factors. Know the family history. Talk to your family members. A lot of times people are afraid to ask, their parents or their uncles and aunts and uncles, who's had cancer before, what type of cancer. But those are important things, and that's important information that your doctor would want to know.
The sigmoid was mentioned as something that was done. Maybe it's still done. Colonoscopy was mentioned. Is there anything else that you sometimes tell patients they can do to screen themselves for cancer?
Well, the first thing is to get people in to do a physical examination. Anyone over the age of 50 really needs a complete physical examination. As part of that, we do a rectal examination, a digital exam, and you may feel something on a digital examination. If not, you do you screen their stool for blood. It's called an occult blood or a guaiac screen. That can be done right in the office. And that's still, I think, the gold standard for what we do as family doctors. If we find that there's blood in the stool, then we usually send them over to the gastroenterologist for further evaluation. When I trained back in 1983, we did sigmoids. I don't know of anyone doing sigmoids anymore. I think the gold standard right now is really colonoscopies. But for the thing I can say to patients is to really make sure you come in and you get screened. What I see all the time is I'll see a 50-year-old for a physical examination. I'll see them the following year when they're 51, and I'll say, well, how'd your colon go? I didn't get it yet. How come? people are afraid to get these things. They're afraid of getting diagnosed. They're somewhat fearful that it's going to be painful, and that's changed an awful lot in the last 10 years. So compliance is really a big thing, and we have to kind of, in addition to harping on, not smoking, eating properly, exercising, we really encourage our patients to go and get these tests done to, be proactive and practice preventative medicine.
Dr. Frisoli mentioned some patients' fear of a colonoscopy. So what can they expect? Should they be afraid?
No, I mean, they shouldn't be afraid. And Dr. Frisoli hit it right on the head. I think a lot of people are afraid of what they may find. They're afraid, that they could have cancer. But in general, this disease is almost completely preventable. You want to do this screening early enough that so if you find a polyp that's growing there, it can be removed during the procedure and actually prevent cancer down the road. I think some people are afraid of the prep. We used to give the prep the day before, and people would be afraid to go to work because they were afraid that they would have diarrhea at work, and it would be embarrassing for them and those type of things. But it's changed considerably. Nowadays, you take the prep the night before, so you don't need to miss a day of work prior to the colonoscopy. You're going to take the prep in the comforts of your own home. It's going to cause a few hours of some diarrhea to clean out all the stool. When they come in to get the procedure done, they're going to get anesthesia. It's not general anesthesia, which is another main concern for people. They don't want general anesthesia. So with the medication propofol, which they'll receive, it has a very short half-life. They will be completely asleep. They won't remember anything. They won't feel anything. You may wake up with a little bit of gas, a little distended, but we encourage them just to pass the gas after the procedure. And it ends up being a relatively painless procedure, but it's a very important procedure. Mammograms aren't comfortable either, but the screening compliance for breast cancer is much greater than it is for colon cancer. And I think if people would just realize that a lot of these things that they're fearful of are not true, we would be able to get a lot more people in and get screened and prevent a lot more colon cancer.
So during the procedure, they're not going to be embarrassed or incredibly uncomfortable, in part because they're sedated and medicine is used to help them relax?
Yeah, I mean, they're going to be completely asleep. They won't feel a thing. The procedure itself takes about 15 or 20 minutes, and it's not an embarrassing procedure for them. Again, they'll be asleep. There's very few people in the room. It's just really the gastroenterologist, usually a nurse, and an anesthesiologist and a technician, so about 4 other people in the room, and no one's looking at them other than the gastroenterologist.
From what I've seen in primary, the bigger change is that it's painless.
Absolutely.
I mean, 10 years ago, they weren't using anesthesia, so you were basically wide awake. You heard the whole thing, you felt everything, and I think the painful part was the air that you have to put into the colon. But now that you're asleep, a light sleep, you don't feel anything, so it's much more comfortable.
Much more acceptable.
Absolutely, and the equipment has also improved. It's more flexible. It's not as rigid as it used to be. So again, that helps alleviate a lot of the discomfort that people used to feel.
Whichever of you want to field this question, what is a virtual colonoscopy? We have a little more of an understanding of what a colonoscopy is.
Yeah, I mean, a virtual colonoscopy is it's an X-ray study, basically, where you get a 3D reconstruction of the colon. It's come up a little bit in the news. I think President Obama just had a virtual colonoscopy for his screening colonoscopy. One of the problems with a virtual colonoscopy, and I think one thing that people don't understand is they come in and they say, I want to get a virtual colonoscopy. I don't want to do a bowel prep. Well, you still have to do a bowel prep for a virtual colonoscopy, so that doesn't change anything. What happens with a virtual colonoscopy is you do the bowel prep, you come in, and instead of being done at a gastroenterologist's office, it's done at a radiologist's office. They take a very small tube, they put it into the rectum just a few centimeters, and they insert air, basically to blow up the colon, and then they do a CAT scan, basically. So you're awake. It is a little bit uncomfortable because you're going to be distended. The real advantage that virtual colonoscopy has is for people who can't get anesthesia. So for people who may have breathing problems, or they may be on anticoagulation, blood thinners, and they can't go off them for whatever reason, their cardiologist feels they have to stay on it, well, that may be a good test for them because it's a little bit less invasive. But obviously, if you find a problem during a virtual colonoscopy, then you need to have a regular colonoscopy to actually remove that polyp. So it could end up being 2 procedures rather than 1. Medicare, as of right now, is not paying for that as an initial screening test, but they will pay for it for incomplete colonoscopies, so for people who had a colonoscopy and the procedure couldn't be completed for whatever reason. Maybe there's a narrowing in the colon, maybe there's some other anatomical reason that they can't get through. You could look at the remaining portion of the colon through a virtual colonoscopy, and they will also often pay for it for medical reasons if they couldn't get a colonoscopy.
Just to add to that, it's also my understanding that, and maybe you can correct me, that it's not as sensitive as a colonoscopy in the sense that they could miss some flat lesions. You know, a lot of polyps are elevated or pedunculated. Some of them are completely flat, and the original virtual colonoscopies, CAT scans, were missing the flat lesions.
Yeah, and that's true. You know, when they did the original studies on the virtual colonoscopy, they were looking at lesions that were 5 millimeters or greater. So we know for larger polyps or masses, 1 centimeter or larger, the accuracy, meaning the sensitivity and the specificity, seems to be about what it is for a colonoscopy. But the smaller lesions, because they were ignored during the initial studies of the virtual colonoscopy, we don't know actually how accurate these tests are as compared to a regular colonoscopy.
Dr. Frisoli, when you meet a patient who has concerns or symptoms, what kind of patients are concerned about colorectal cancer? What kind of symptoms bring people in to ask you about it, and which ones actually worry you?
Yeah, the symptoms are very varied. I mean, it takes a while for colon cancer to develop. So sometimes they'll just come in and they'll say, I noticed blood when I wiped. You know, now that could simply be a hemorrhoid, it could be a little fissure, or it could be a rectal tumor. So that's one of the symptoms that we always look for. So blood either on the toilet paper, or if the stools become very dark, which we call melena, can imply that there's some bleeding in the colon somewhere, you know, more proximally, higher up. So that's one of the symptoms. Fatigue. Sometimes the patient will look pale, or they'll say, I just don't feel right, I look pale, and that could be an indicator of blood loss. We might do a CBC, a complete blood count in the office, find them to be iron deficient anemia, and then we work them up for where this blood loss is coming from. Some other symptoms may include just some abdominal bloating, abdominal pain. They often will tell us that there's been a change in the frequency and character of their stool. Sometimes they describe it as ribbon-like. It's become smaller, it's not quite the same. They may have persistent nausea and vomiting that they just can't understand. They may have a weight loss. Some people describe just an incomplete evacuation. They say it just doesn't feel the same way. I'm not evacuating like I used to. If a colon cancer is ignored, then they may come in with severe abdominal pain, with bloating. These tumors can be invasive. They can invade the entire lining of the colon, and then you can get an abdominal infection called peritonitis, and they can come in awfully sick. So the gamut of, you know, something really mild to just some fatigue, some weight loss, to severe abdominal pain stretches the whole gamut of colon cancer.
So in addition to the risk factors and the screening groups we talked about, if patients have some of those symptoms or concerns, they need to go visit with their doctor and get checked out. Absolutely.
They need to tell us. We as primary care physicians will examine them in the office. We'll do these rectal examinations, as we said. We'll check their stool for blood, and then we get them over to the specialist for further evaluation.
Yeah, one thing I would add to that is besides all those symptoms, some people actually have no symptoms. And that's, so one thing that people should just be aware of is just because they don't have symptoms doesn't mean they couldn't have an early cancer. So even more reason to get in, get your regular checkups, because you may not have symptoms early on.
We've heard mention polyps, we've heard mention cancer, tumor. Could you just help me understand better, you know, what are those different things? Are they related?
Yeah, I mean, a polyp is just a growth in the colon. Cancer is an uncontrolled growth. You know, so a polyp could be benign, like what's known as a hyperplastic polyp, which is probably about the equivalent of like a skin tag. Okay, it carries no cancer risk. It doesn't become cancer. And even if they are found in the colon and not removed, they don't become cancer. But there's also something called an adenomatous polyp. or an adenoma. People may have heard of this from their doctor. And these type of polyps have the potential to become cancer. So when you have a colonoscopy, when these polyps are removed, the polyps are sent to a pathologist who examines them underneath a microscope to determine what type of polyp they are. And these adenomatous polyps can become cancer down the road. So that's why when they're removed, you can actually prevent cancer by removing those type of polyps. Now, not every one of them goes on to become cancer. Actually, the majority don't. But because there's no way to tell which polyps will become cancer and which ones won't, we remove every polyp that we find during a colonoscopy.
If you don't have a polyp but you have another kind of abnormality, let's say that is a colon cancer, do you need other tests to figure out what kind of cancer you have? How bad is the cancer? What is that process?
Yeah, I mean, you may, usually when we find an abnormality like that in the colon, oftentimes, besides, obviously taking a biopsy, which will give us some information as far as what we're actually looking at, you may need some type of other imaging test. You may need a CAT scan to look at the remaining portion of the abdomen. If there's a mass there, sometimes they'll even do a CAT scan of the chest to make sure it hasn't spread somewhere else. Sometimes they will do a PET scan, which is a special test which looks for metabolic activity in other parts of the body. A lot really depends on what is found and what its location is.
Dr. Frisoli, can you just briefly tell me, when a patient is facing colon cancer, what things do you tell them that they might face as treatment? What options do they have? What obstacles do they have?
Yeah, the treatment and the options really depend on how quickly we diagnose it. If we diagnose somebody with colon cancer in the early stages, what's called stage 0, and it's really it's carcinoma in situ. It's just limited to the mucosa. It hasn't really spread. As Dr. Gingold said earlier, that's a curable disease. So the gold standard for that is colon surgery, colectomy, and your survival rate is just phenomenal. If a patient waits or we don't diagnose it soon enough and it starts to spread, it can spread to the lymph nodes, which could be a stage 3 or 4, and then it could, beyond that, a stage 5, it goes to the organs. It can go to the lung, it can go to the bone, go to the liver and the brain. Then the treatment options are much more difficult. So it can be as simple as a simple colectomy to remove it. If it has spread to the lymph nodes, then they usually add chemotherapy. If the colon involves the rectum, radiation therapy often will help.
Dr. Gingold, tell us a little bit about what Dr. Frisoli is mentioning here. Tell us a little bit about the treatments that a patient might receive if they're at the Colon and Rectal Cancer Institute at Steeplechase Cancer Center. How do all those different options that he mentioned and those different therapies, how do they get sorted out?
Well, again, a lot depends on what the stage of the cancer is. It also depends on what type of colon cancer it is, meaning that treatment for colon cancer is often different, potentially, than treatment for rectal cancer. As far as colon cancer itself, if it's stage 1 cancer, basically the prognosis is excellent. It's about 90 or 93%. For rectal cancer, it's still very good, but it's not as good. It's about 70 or 72% or so. So those are the top end of the spectrum. When you get down to stage 4, you're talking about for colon cancer a prognosis, meaning a 5-year survival rate of less than 8%, and for rectal cancer it's less than 4%. So which is why you want to get diagnosed early. When you are diagnosed, depending on what stage you are, will determine what type of treatment you have available to you. Surgery is pretty much for everyone, for the most part. If you have stage 3 cancer, those patients will often get chemotherapy, adjuvant chemotherapy. They'll get typically like what's known as Folfox, which is 5-FU, oxaliplatin, and leucovorin. Stage 2 disease, some patients will get some chemotherapy, some won't. That's still some of the studies have been mixed as far as the benefits for chemotherapy for that disease. For stage 1, they typically don't need chemotherapy. When you're talking about stage 4 disease, Surgery at that point, even chemotherapy at that point, is typically salvage therapy. Oftentimes it's not treatable when it gets that advanced. So they may try you on some type of experimental regimen or some type of new protocol. And surgery at that point is usually to prevent some type of blockage, to prevent problems down the road. As Dr. Frisoli had said, with rectal cancer, oftentimes they will get high-dose radiation along with surgery at some point.
So we covered a lot of ground today. We talked about screening, we talked about diagnosis, what people can expect from a colonoscopy, what they can expect when they visit their physician. You talked a little bit about the Steeplechase Cancer Center approach to treating the patient with different disciplines. If we have to leave people with one message about colorectal cancer detection and treatment, what message would you like to leave them with today?
I would say that colorectal cancer is preventable for the most part. Genetics does play a role, as Dr. Gingold said, but the key thing is just to live a healthy lifestyle. Those are the things that reduce your risk factors. Exercise, eat a high-fiber, low-fat diet, eat fruits and vegetables. Do not smoke. Don't drink a lot. Drink in moderation if you drink at all. And by all means, get checked. Do preventative care. Go to the doctor. Go to the family doctor, your internist, and get checked if you have any concerns, any signs or symptoms, any rectal bleeding whatsoever, any abdominal symptoms, nausea, vomiting, weight loss. Rather than ignore it, get it checked. The sooner you get it checked and the sooner you get diagnosed, the better the prognosis is overall.
Dr. Frisoli, Dr. Gingold, thank you very much today for sharing these ideas and helping our patients.
Thank you.
Thank you.
This concludes today's episode of Somerset Medical Center's Health Talk. Please remember that the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral number at 1-800-443-4605. For information about colorectal cancer and services available at Somerset Medical Center's Steeplechase Cancer Center, please visit www.steeplechasecancercenter.com. Thank you for watching.